We generally have poor health literacy about what's going on with their pelvic floor, what it looks like. They've no visualization in their mind eye of what that muscle group is, what the pelvic organs inside it look like. And so they usually are like, everything's fallen out or everything's collapsed down below.
You're listening to the Active Mom Podcast with host Dr. Carrie Pagliano. I'm a mom physical therapist and your go-to guide for staying active with pelvic health issues in pregnancy, postpartum, perimenopause, and beyond. Whether you're a fellow mom, physical therapist, or women's health professional, join me where I'll share expert insights, real-life stories, and the latest research to help you approach running, CrossFit, yoga, Pilates, HIIT, or whatever activity you love with confidence and evidence-informed guidance. Let's start the show. All right, welcome back to the Active Mom Podcast. We were talking about, this is the third time on for our next guest. She is a huge friend of the show, and we're lucky to get her solo today. Gráinne Donnelly, welcome back. I mean, I don't even know how to begin to introduce you because you just wear all the hats. So give us the quick rundown if nobody's heard of you before. What are all the things you do?
I'm delighted to be here. So I am. And it's always a huge honor to be asked to come onto your podcast. And I didn't realize until you reminded me that this is the third time, although she did tell me that one of the times I didn't realize it was on the podcast, but it was on the podcast.
You were, but you weren't. It's all good.
I'm a physiotherapist based in Northern Ireland, which is actually part of the UK. I'm undergoing my doctoral research journey at the minute, and I'm doing a few kind of other sort of research endeavors. And I'm on the board of trustees for the POGP, and I'm also the editor-in-chief for the Journal of Pelvic, Obstetric and Gynaecological Physiotherapy. And yeah, that's really me.
And Mama 4.
Oh, Mama 4, my baby. We're talking about off recording about just how it never stops. So anyone out there who can relate, yes, it never stops.
Yes. Exactly. So some of you may know of Gráinne from the 2019 UK postpartum return to run guidelines. She worked on that with Emma Rockwell and Tom Goom. And I think that's kind of the first time everybody started to kind of realize you as a household name. And you've just become such a great inspiration for so many of us and all the work that you're doing. And we really don't know when you rest. So when I was compiling what to talk to you about today, I was like, I want to be sure that we hit some research, but I also want to know kind of where your head's at on a couple of things, because we had you and Emma on to talk about kind of where the postpartum guidelines have come and all that sort of stuff. But I want to get your head as far as like, we've gotten so much research updates in the last couple of years, like, are we measuring the right things to know what we're doing? And I think that's ultimately kind of where I want to end up today. But I want to start with this 2025 study, so recent. So looking at pelvic floor dysfunction, running kinematics, pelvic acceleration in postpartum women. Put that in plain English for the moms in the group. What were you looking at, and what was the hope that you guys would find here?
Great question, Carrie. This was actually a study that was led by Dr. Celeste Coleman and Dr. Izzy Moore, who are actually both my PhD supervisors. So it was a huge honor for me to come along on the journey with them. And actually nested within that, I've done one of my PhD studies, which I'm currently writing up. So we'll be, stay tuned because there'll be a build on from this. But I guess this study was basically looking at, we hear so much about sports and pelvic floor dysfunction, and maybe as clinicians, we have our own ideas about what pelvic floor dysfunction might do in terms of someone's movement or ability or performance. But yet we don't entirely have a lot of research to either substantiate this, inform us, guide us. And so this study was, I guess, a starting point because it was looking at simply a cohort of women and looking at their pelvic floor symptom severity or their expression of symptoms using validated questionnaires and also collecting data. So that's where my involvement came in. I was the pelvic floor physiotherapist who did pelvic floor assessments and gathered data on that. And in this particular study, we reported as per the modified Oxford manual muscle testing scale, but actually in the series of research, we did POP-Q measurements and we did a lot of stand and lie and stuff. So we did a lot more in the pelvic floor domain, but that will come in the second paper. And we really wanted to see, because beforehand, when we were hypothesizing what to even look at,
Yeah.
I guess the pelvic health clinician in me was like, well, we sometimes think that, even trunk flexion angle might change, some sort of like hip drop, different things, like what sort of things might happen. Could there be more leg stiffness? So lots of things hypothesizing. But interestingly, the study didn't show any significant
Right.
variations across the cohort. It did show some trends and some relationships in terms of the participants with higher pelvic floor dysfunction symptom expression actually had higher degrees of low frequency shock attenuation of the pelvis. And we tend to think of low frequency shock attenuation being involved in things like more muscular activity in and around the pelvis and potentially lower limbs. So was that suggesting that, there's a lot more required of a wider lumbopelvic anatomy in those participants? We don't know the answer to that. We just know that it showed up as a trend. And actually,
Right.
findings from the second part of the study will build on that, because I was investigating compression garments in
Right.
this nested cohort that had a certain level of symptoms and above. And we got them running in randomized order with and without the compression garments, and they actually showed then they did still attenuate low frequency shock attenuation at the pelvis, but they needed less of it when they were wearing the compression garments. So the compression garments were obviously attenuating some shock, and there was a less jerkier pelvic motion, which meant they were smoother. There was less, the acceleration was less all over the place. So there's definitely some pelvic biomechanical parameters that have shown up there, and it aligns with the trends that were being found in the wider group study. So it's interesting overall that we're seeing something. But the main thing I would highlight, and one of my frustrations with research and the difficulty with it, is that we did recruit a symptomatic cohort, but overall, compared to what you and I see in clinic, they were on the milder end of the scale. And I would like to know what would happen if we had more symptomatic participants. And it's just really hard to recruit for, because, the women who all participated, we recruited and reached threshold, no problem. And people were really motivated and interested, and people genuinely want to help this area. But possibly the more symptomatic women don't want to go into a lab and leak on a treadmill, or, it's quite a vulnerable thing for women to come in and expose themselves in that way. I don't know whether that's it, or whether we're just not recruiting in the right manners, because we rely on social media quite a lot. I'm not sure. So yeah, it'll be interesting for the future.
Well, if they're really symptomatic, are they even running?
Well, that's it.
Yeah.
And that was one of our exclusion criteria, because we were doing 2 studies back to back. We had to make sure that they could that they were safe to engage in the duration of the running test. So we had to make sure they could run for at least 30 minutes. So as you said, some of the symptomatic women may not have returned to that level of activity. So they were excluded before they even began.
Well, and some of the participants did have symptoms during the test, right?
They did. They reported a leak or a heaviness, or even some back passage symptoms. So there was definitely the symptom expression was coming up during the test. And even during the pelvic examination, it was I was blinded because I was blinded to how symptomatic people were. I didn't know if they were on the very, very normal end of the scale or the larger end of the scale, but I actually quite enjoyed playing the game of, do I think this person was in a symptomatic group or not? Because, you're getting signs from a pelvic health physiotherapist point of view in terms of pelvic muscle function, but pelvic organ support, and even the reluctance to Valsalva was very telling. It's very intimidating for someone to do a full-on Valsalva if they're going to be symptomatic.
Well, so you made a really nice segue here, whether you realize it or not. How hard is it? And this is why I will never do my PhD. Never. How hard is it to sit there as a clinician and, try and figure this stuff out, and then end up with a study that you're like, okay, it tells us a little something, but like, what the heck is going on? Because there's some people that they swear they can look at somebody and tell if they're symptomatic. I'm like, I don't think you can. But let's dive into kind of some of those questions of when you are, when you're coming up with these questions to research, there's so many variables. How do you figure out as a clinician, when we don't necessarily have anything concrete, when that person, let's just say they have low symptoms, let's say they have leakage somewhere in a 30-minute run, how do you figure out where to start?
As a clinician?
Yeah.
It's really hard because I do know what you mean. Like, I suppose going into studies like this, I already had my, whether I want to, put my biases aside and things, you
Right,
always have what you think you will find. Like, I think we'll find this in this study because this is what I see clinically.
right,
And it's really interesting that there was no significant changes across the cohort. Yes, we can come up with reasons for why we may not have succeeded in
right,
capturing changes that actually do exist,
right,
but they're just suggestions. Maybe if we had met the criteria that we've highlighted and the limitations, we still wouldn't have found a significant difference. And it's
right.
interesting because a lot of our pelvic floor dysfunction symptoms, even though they can be tangible and objective measures in terms of like if someone leaks, they leak, but they're
Right.
still very perceptually subjective in the sense that that might bother you, but it doesn't bother me.
Right.
And how bothersome something is, and the perceptual element's really important. And that's why I'm really keen to embed some of that perceptual data into my PhD because I
Mm,
guess my overall want for my studies is to be as close as possible to clinical practice while still undergoing quality
right.
research. And that's where there's sometimes a bit of a disconnect
Right.
because I don't have the controlled participants coming into my clinic who don't meet a certain, I don't meet them at the door and go through an eligibility criteria.
Right.
I
Yeah.
have them all in. And they don't just have one simple presentation. They have a whole myriad of
Right.
past medical history and complexities and lots of things intertwining. And so this is where I find research and clinical practice a bit disjointed. And
Yeah.
so bringing in my PhD, I want to capture the perceptual, mechanical to see if we can find any objective sort of tangible changes, but
Hmm.
also the symptomatic based ones and not just via validated questionnaires. So in one of my future
Right.
studies, I'm hopefully going to do a pad test so that we're actually collecting
Hmm.
like symptom loss and not perceived symptom loss.
Right.
So I do find that, so in that way, I'm hoping to try and capture elements of the biopsychosocial approach that we take
Hmm.
rather than just being looking for mechanical changes or just looking for patient reported
Yeah.
symptoms. I want to try and get more of what we do in clinical
Uh,
practice because we take all of it.
right. Yeah, no, I completely agree with you. It's one of those things that like it's so there's so much nuance and there's so many different aspects to things. Like how do you quantify that in one study with and I'm just thinking about those 25 people and you know, let's say they all had, stress urinary continence. To me, my first thought is that there has to be at least 25 different reasons why each of those people came to have symptoms. So even just with your foundational data set, like there's going to be variability there. So yeah, it's never going to be a clean data set to me. And that's okay. But like, it also makes me sad every time you get a paper that's like, oh, well, it's not this. I'm like, is it not that? Or I don't know. It just, do you
Yeah,
know what I'm
and
saying?
I do know what you're saying, and it's funny because in the so say if my head always keeps going to I suppose the compression garment research that I'm doing, and say we are starting to find some changes, so we know that there's perceptual changes that have shown up significant. We've identified some mechanical changes around the pelvis, which is quite exciting. So I got excited at that
You
because
got
part of
something.
me, well, part of me thought that we would, especially when we did the wider analysis and find no significant
Right.
changes. I was like, oh well, we're not going to find any change. Again, my assumption, we're not going to find any changes in this sub nested trial, but we did, and I was like, oh, that's exciting, right? But what does this mean? Um, and then, but the why of it, when I start to kind of like, I'm not going to answer the why of it in my PhD, but when I start to think about ways I can discuss it, I think the reason why they help people will be different even within
Right.
individuals. Some people will
Yeah.
have more distensible connective tissue down below and benefit from that stiffness. Some people might respond to the circulatory changes that are happening because there were
Right.
compression in around that area. Some people may just perceptually feel I'm better because I feel snug, and suddenly their inhibitions are gone. I just think I do agree with you. I think there will be multiple individual reasons. And will
Yeah.
we ever have the answers, Carrie? I don't know.
Don't say that. Um, no, but okay. So pretend for just a second that you're a relatively new physio and you're trying to help your athletes, and you're reading this study. What should a newer therapist take from this? Because I remember back in the day, um, I'll use Karibo for example, is she would do a paper and it would kind of tell me something that I thought that I was like, okay, well, yeah. but it didn't really tell me anything new. And this isn't telling me anything necessarily new. So what are we hoping to take from this? Like, what are you now taking forward and saying, okay, well, it wasn't that, but what questions are you generating now?
Well, first of all, what I'm generating is that we don't have strong enough evidence based on this. So this is only a small study,
Yeah.
but we don't have strong enough evidence. It certainly doesn't substantiate any of the blanket statements we might see out there, or the assumptions. So we need to now
Yep.
scrap all those assumptions, which is a lot. We're seeing a big shift in female athlete health, postpartum, return to sport, and what we understand about it. And
Right.
this is kind of echoing elements of that, in that we're talking individualized changes here. So we can't make blanket
Yep.
blanket assumptions that having pelvic floor dysfunction is going to affect your running gait in any certain way. I
Yeah.
think, so there's one thing you can take from it.
Okay.
The second thing is we're highlighting that, do you know what, for various reasons, it was a small enough sample, although large enough for biomechanical studies, but it was a small enough cohort. They had to be able to run a certain amount. So we probably did wean out some of the more symptomatic participants.
Mm-hmm.
They were only running short duration trials. So a lot of our patients have to
Right.
run further into their run before they
To have
expose
symptoms.
symptoms.
Right. Yep.
So we didn't have a study that captured that.
Mm-hmm.
And they were treadmill running. It wasn't even their usual running
Right.
route or anything like that. So there's a couple of nuances that limit. It depends on what way you look at it. They either
Yep.
support or limit depending on what you're looking to answer.
Yeah.
But I think it was a really good starting point, because now we have some reference data that, there's very few studies. When we were
Yeah.
writing up this, there was no studies really to discuss against in terms of a lot of those mechanical running gait measures, certainly done in women. And
Right.
any studies that have done them, actually Rita's study, Rita Deeran's,
Yeah.
one of her PhD studies on diastasis in runners was actually
Right.
really interesting for me to read, because when I read it, it's funny what you take when you're reading papers. The first times I would have read it, I was focused on the diastasis,
Yes.
so I was looking for the diastasis related, and I probably scurried over the running mechanics, I didn't understand it. But then I read it, I was like, oh my goodness, she did loads of running
There's some stuff in
mechanical
there.
data in it. Yeah. So I was like, that is so interesting. And now reading that with a new appreciation, going that I know how technical and different, I know how much
Right.
is involved to gather in that data. So that was really interesting. But we have very few studies that have a lot of reference data. So at least if someone goes and builds in this research, they now can
They've got
compare
that.
against.
Yep. No, that's fair. That's fair. So let's go back to you clinically for a second, because I'm always curious what other practitioners are doing in clinic. Can you take us through, if you have someone that comes in, let's just say, oh gosh, let's come up with kind of two examples. One would be they leak later in a run or something like that. Kind of like, somebody we were talking about with this this study here. Where do you start? And kind of just take us through like a quick framework of how you might take them through an evaluation, and not necessarily what findings you would expect, but like in general, what are some possibilities if they're running late, if they're having leakage later in a run to you?
Well, first and foremost, the subjective and assessment and what they tell me
Yeah.
is foundational. Like, I've already built a lot of my work and hypothesis based on their subjective
Yeah.
assessment. So I
Yep.
find that the
Exactly.
longer I work in my career, the more weight goes to my subjective assessment.
Yep.
It means more to me, or I understand more. And the lived
Yeah.
experience of the participant tells me much more. It's not about me and what I think, it's about what they're telling me.
Yeah.
So I will take that and I'll harness a lot of information, because they're basically telling you, they're directing you to the answers in many ways.
Yeah.
So I'll take that. But then what I want to do is I will look for my objective assessment to see. So subjective assessment's what I hear. Objective assessment's what I can see externally and feel. If we're talking specific to the pelvic floor, obviously you're doing a wider assessment, but I will look for pelvic floor. I will do the modified Oxford still, even though it has its own limitations and its own issues. But I will do that and get an idea of, like, are they fatiguing? Is there any signs of fatigue even within a modified Oxford assessment? But then I'll also use transperineal ultrasound, because again, I find the layering of this is like, it gives the eyes to what I've already seen or heard. And so it's either another element of information that supports any working hypotheses I have. But I want to look at, whether they have good structural support in the pelvic floor, whether they're actually engaging pelvic floor
Yeah.
correctly, and can they do that? And what are they like? Is it coordinated? Is it uncoordinated? Do they fatigue out? But then what I want to do then is get an idea. So they've told me they don't fatigue out until 40 minutes into their long run.
Mhm.
So we're kind of reaching a load capacity threshold. So for that
Yep.
first 40 minutes, they're okay. So the
Yeah.
pelvic floor is actually doing okay. So it's all
Yeah.
about contextualizing it to that individual and going, right, okay, just like any other area, if it was your calf or hamstring, we would be training up that area so that it can expose itself to more load and take the demands
Right.
of that area. I'll also want to look at how they're running, because I know myself, when I would have trained double unders after having babies, even getting back to double unders, I would have known that I would have had been able to do maybe the 7, and then on the 8th one, I'd already feel myself starting to stiffen up because I know the
Yep.
next one could provoke
Yes.
symptoms. And I was
Yep.
like, right, okay. And so that's how I kind of trained myself to my fence and kept increasing reps.
Yeah.
So, but even though I knew I didn't want to stiffen up, because stiffening up was making me more rigid, more impacted, it was this innate sort of reflex. I couldn't control
Yes.
it. Like,
No, you can't. Mm-mm.
no. So I was like, oh, it's so interesting, because I want to see what people are doing when they're running now. Are they kind of, when they get to that interchange of that 40 minutes, are they now getting stiffer? Like, are they getting, is there anything
Right.
changing? And again, that might be individual to what you do, as to what I do, as to what someone else does. It's how their
Right.
body tries to attempt to accommodate for whatever load
Yeah.
deficit it's
Yep.
identifying. And so then I would try to see, can we give any strategies that might modulate that and assist
Yeah.
that. But obviously, I would also think about compression garments, because the more I'm researching, the more I'm seeing a role for them as an adjunct, not as an answer, but as an adjunct.
Yeah. Bunch of questions there. One, do you have a preference of doing internal before your ultrasound or ultrasound before your internal, or do you just depends?
I do the internal before the ultrasound, just because, more from infection control run, I kind of think if I'm going to be doing
Okay.
it, rather than getting then gelling and whooshing things up, I do it in that order. But if I was to choose one to do, I think I would prefer ultrasound. I think I see and tell more from the ultrasound. I can see, yes, I'm not creating
Yeah.
activity, but I can see the lift. I can see what's happening in the tissues,
Yep.
the response. I can see so much more. So
Yep.
if I only had, if people were only allowing me to do one, it'd be ultrasound.
Yeah. And then do you always do pelvic floor before assessing the rest of the body, or do you have situations where you might prioritize a movement screen and then do a pelvic floor assessment in a different session?
Yes. So usually I would do when I take the subjective, then I'll do a little bit of a wider screen on things. So I might be looking at hip, a bit of like impact or
Yeah.
movement, and then I'll go to pelvic floor. And then if I think that there's something that we're really having to try to provoke, I'll probably get them back the next time. And
Yeah.
if possible, and it doesn't always work out, because again, we're dealing with busy moms who are squeezing in an appointment.
Yep.
But if you can get someone to have went for their run, and hopefully, I suppose, nearly prior to their appointment, so that they're hopefully putting it under load. I want to see what their rep was presenting like then. Um,
Yeah. Yep.
and I have a colleague, Biljana Kenaway, is in Geneva actually, and I don't know whether her clientele is different, and she's getting people in, but she actually gets them running and then running to their appointment in clinic. Then she'll assess them at that point.
Wow.
So it's so
That's
interesting. I
nice.
just find, when I talk to her, I'm like, it's so interesting. She would find a difference, because she's now bringing them into whatever zone it is that they're
Right.
exposing themselves to load. So I find that fascinating.
Oh, that's really neat. Um, if you do one before the other, and I've tried to figure this out myself, you know how you just do things and you don't really know why anymore, and you can't necessarily explain the steps that made you get there. Like you just kind of leap ahead to that's what your spidey sense, I guess, says. Why would you, what sorts of situations would you go and look at a movement assessment before diving into looking at pelvic floor first, do you think? What would be any indicators, either objective or subjective otherwise?
Um, if there's someone who talks about leakage being provoked very easily,
Hmm.
rather than the 40-minute run, I want to see, like, what way they are moving. If
Yep.
I will do it then, depending on whether there's other coexisting symptoms. So if someone has pelvic floor dysfunction symptoms, but they've also some sort of lumbopelvic pain or hip pain, I will definitely go into a movement screen there because I want to know what's going on with other areas, and then layer
Yep.
on the pelvic floor to see how that's all linking. But I guess it depends, and yeah, what their main
Yeah.
concern is and what they're coming for. What about you?
Yeah. I've tried to figure that out because I have certain people that I feel like I need to see how you move first. And sometimes I might run them quickly through portions of a run readiness screen just to see, hey, where's the volatility? I guess that's kind of how I think about it. And then if everything looks clean there except for the impact, then and I'm actually talking to her later on today. I've been using Celeste Goodson's and it was not meant for this at all. She has that paper with like progressive vertical impact drills,
Yes.
and I have been starting there, and even like put a step in before and did bouncing before. And like, if you're volatile on a bounce, we're not going to hit these other things. There's going to be a problem. But like it's almost like you would do with chronic pelvic pain. Like you need to go to that like safety, that sub symptom threshold, and like show the body that it's sort of safe in doing some sort of oscillations or whatever, and then slowly building that up. And again, I have no idea what I'm doing. Does it really, is it really vertical impact that I'm training, or is it a multitude of other things? I don't know. But like with some people, I also think too, there's a subjective piece that you kind of mentioned earlier. Like if they're really focused on one thing, like if it's like jumping jacks or doubles or, downhill running or things like that, I feel like if I don't look at that immediately, that's not validated. And I've had patients come to me for multiple, for another opinion or something, and they went somewhere else and all they were doing was internal work
Mm-hmm.
or internal assessment. They didn't even look at them move. And that patient was upset that that bigger picture thing wasn't even addressed. So I feel like that sometimes is part of it too. Like when they're telling you, it's almost like I want to say to them, what is it that you want me to look at today or to be sure that I include so that you feel, because I do that buy-in, I think, is so incredibly important to it as well, to getting them to understand why you're having them do all these wacky things.
Oh no, I totally agree with
But
you. And actually, I've seen the same sort of thing come in with a lot of my patients. I don't do the internal vaginal in both lying and standing. I do the internal in lying, but I will definitely do transperineal in lying and standing. And I find
yeah,
that when they really love the fact that you're looking them in a function position and maybe get them moving and
right.
things, even from
Right.
a psychological point of view, because a lot of our patients come and the perception that it fascinates me, the perception of patients when they have pelvic floor dysfunction, like what they
Yes.
think or believe is going on, because we're talking a blind area here that
Yep.
the general public has poor health literacy about. Even if we are
Yes.
educated people, we generally have poor health literacy about what's going on with our pelvic floor, what it looks like.
Yeah.
They've no visualization in their mind eye
Right.
of what that muscle group is, what the pelvic organs inside it look like. And
Yeah.
so they usually are like, everything's falling out or everything's collapsed down below. And it's
Right.
when you then are able to show them and they're like, oh, that looks the same as lying. And I'm like, yes. And they're like, oh, wow. You can just see this modulation going on, or you can see them
Yes. Yep.
recalibrate. And they're like, so
Yeah.
everything's not falling out once I'm upright. And they're like, so it's nearly that you can start to desensitize maybe what
Mhm.
happens or what thoughts go into their mind when they start running and they maybe feel some symptoms, that they're not going
Yes.
to catastrophize, and that they can kind of understand it a little bit better. Because
Yeah.
any other area, like I always explain it, I know it's pain and it's different, but if you stub your toe, it's really sore,
Right.
doesn't add up to the severity of the injury. But before you look at that toe to rationalize that injury, you're like, oh no, this time the nail's gone. Like I've done it this time because it's so sore.
Right.
And then you look down, you're like, oh no, it's okay. Now
Right.
it's still throbbing, still really sore, but you believe that you're going to be okay. So you know
Yeah.
that those symptoms will resolve. Whereas pelvic floor issues, because we have access to social media and information on demand, but it isn't always the accurate information, women
Yeah.
are getting snippets of information. They are hearing things that can go wrong. And what happens then is they get symptoms. They think that everything's collapsed. There's no way of validating this, and there's no way of rationalizing it. And so those symptoms can continue to be sensitized and things. So I do think there's an
Yes.
element of that within pelvic health as well.
Yeah. No, I agree. And I've been doing I started doing transabdominal ultrasound probably 15 years ago with a sports physio from Australia that I was working with. And that's when I stopped doing, the regular vaginal biofeedback, and just having the ability to show something about your body in black and white, and you don't have to trust me. Like, I think that it takes our subjectivity out of it to a degree, to be like, this is what you think the pelvic floor is in your brain. This is what we're looking at here. This is what you're feeling. That's what it's doing. It kind of takes me out of the middle of it. But again, it helps connect them more. It destigmatizes, educates. I don't know what the word is, but like, that's been such a huge tool to give people more information about their bodies, instead of these assumptions and these things that have been told. But like, to jump on what you were saying about social media, like, I feel like, yeah, that's a whole other mess and a half. Is there's like these half truths, and then it goes off the rails. And when people are citing research, and I had this happen the other day, you click on whatever research they cite, and it's not even about what they were talking about in the first place. So like, the blog post was referencing research on, I think it was like barefoot shoes and pelvic floor or something like that. And they cited a study, and the study specifically said nulliparous, and like had nothing to do with, I'm like,
I know it's like people want to make the associations that maybe they see or that they believe, and that's a really hard part of it. But it's interesting. The social media one is mad, because one of the studies that I mentioned to you that we hopefully will have coming out soon was on diastasis, and I suppose the impact of Instagram on people with diastasis, exercise behaviors and perception. And I guess a lot of it comes down to the algorithm. I did the interviews, and like,
it does.
if you fell on good content, if someone was following your page and getting good evidence-based information, they tended to see more suggestions of people like
Yes.
you,
Yes.
reinforcing evidence-based messages. So they tended to be the people who were really empowered, not fearful, a bit more realistic about what diastasis is, what the goals or outcomes of rehab are. Whereas the people who fell on non-evidence-based information tended to follow a lot more, go down this rabbit hole, and they were very fearful. They were lots of mixed messages, really disempowered, afraid to move. And a lot of even blame culture, where people think that it's something they did during their pregnancy that or didn't do, and you're like, it's just the power. Social media can be a really great tool, but it can be a very detrimental tool, and whether we like it or not, patients are looking for their information there.
You've got
because
to navigate
it's easier
it.
to access. I've heard different sort of clinicians and academics say that we need to just stop. People shouldn't be going for information, and I'm like, but that's where they're going, because they can't actually get into the GP because services are oversubscribed. Right. They maybe don't know where else to look, so it comes up on social media, and that's exactly they're sitting pinned with a baby, and that's exactly where they're getting their information.
Right.
So we need to do better.
Yeah. Well, and that's the thing. Again, and I've been trying to just clarify to people too, like, so much of this is marketing. And when you understand marketing principles, you're trying to find people's pain point, and you're trying to get to them emotionally. And this is a very emotionally vulnerable population. And so if you're speaking to that pain point and going in and getting them emotionally, then it can go one of two ways. It can be either supporting it with actual evidence and helpful information, or it can be feeding that further. And that the algorithm, you're so right about that. I had somebody DM me the other day, and she's like, "Oh, your approach is so refreshing. Everybody that I see says that you've got to do a pelvic floor contraction with every single rep of every single exercise." And I literally wrote back, I'm like, "You were in the wrong algorithm."
I know, but it's
like, I don't know how else to say it. Like,
it's like it's unbelievable, because the power that algorithm holds, and people don't even realize that they're in there. Do you know what I mean? Like, people don't even realize that they're getting an echo chamber of the same things that they're looking at, or the same things that they're talking about.
We've got a few parallels going on over here in the States right now. So yes, I understand this more than you know. Yes. That's an after dark conversation.
That is an after dark.
Separate drinks.
Guys, it's coming. Just so you know, it's coming.
No, but but I think this is the part where, because clearly none of us have enough time or energy on our plate to go after every single person. And unfortunately, it ends up being a lot of people who we're pregnant, they had a problem, they did something, and they don't realize why they got better, or they think the thing that they did made them better when it probably was just genetics, or they didn't necessarily have the problem or whatnot, and they're actively making their money off of it. And I think we need to just, when we look at that information, acknowledge that that person, I am their avatar, meaning I am the person that they are trying to sell to. And I am very open about that too. Like, even though I am an educator, I also have a small business. Like, that when I have to do marketing, this is part of, how I feed my children. Like,
Yeah.
but I'm not, it's not like I'm trying to hide it either,
Oh,
so
yeah. And you've no agendas, or you're not preying on people.
no,
You're actually actively trying to help people. Like, you
right.
are the algorithm we need.
Exactly. Well, but this is the part where I get a little unnerved, is when there's people that I think should know better. And they're
Yeah.
actively like, you can only get out of bed like this when you are pregnant. Like, really? And so then, how do you take those things and gently encourage people to come over? Because I don't want to go after my friends and being like, you're full of crap. Don't say that. I want to be like, hey, why don't we consider, I mean, just looking at the postpartum guidelines that just came out of Canada, looking at, you know, oh gosh, was it that, or it's all blending in my head? Oh no, it was Amy Mullick's work, where she was looking at like bench press in pregnancy and postpartum. Like, we're on our backs now. We're doing ab work. Like,
Wow, I
we
need
can
to
do
see that.
these things now. Yeah, no, exactly. And it's like, you're in one camp, you're seeing this, and I think we're at the tip of the spear, and we're really kind of seeing these changes and shifting the paradigm and whatnot. But yet we still have people with millions of views who are physios saying, you need to, when you're pregnant, be very careful, roll to the side, get out of bed. I'm like, and how do you, again, it's all marketing again, it's nuance. It's like, for some people, I may recommend that because it may help, control their symphysis pubis pain or back pain or something like that. But if you feel great and you're doing fine and you're doing all these other things, no, you don't need to be careful and gentle, and like that's very 2010 2000 2000. So it's like we are in a position of privilege where we see all these things, and we were talking earlier about how much difference there is across the globe in practice patterns and things like that. Like, how do you appreciate all of it and still try and kind of bring people along with you, be like, hey, we're on the spear, how do we bring everybody up behind us without losing our sanity in our minds?
It is, because even in things like when I think about diastasis, and because
Oh, go
I
ahead.
educate in diastasis, and I'm actually going to do a course in Belgium this weekend on it, and I always get really excited doing that. But then sometimes, depending on where I go, I realize, oh gosh, like, because I always think everybody's where we are with the evidence base of diastasis, and then I realize, oh wow, there's still very much embedded beliefs of kind of like what you're saying 10 years ago, what we used to do then, and like,
Yeah.
and there's nothing wrong with that. At one stage, that was the evidence base I was pulling off, if you know what I mean. And so that's so aligned with some of the things I thought 10 years ago, 15 years ago, or the way
Right.
I was educated and taught. And it is difficult, but then you have to be like, okay, this is an opportunity, because, and
Right.
you have to approach it in the right way, because it's really scary for people to see too much change. Like, people don't like when they've been taught something with conviction by someone who's maybe an expert in their field, in their region.
Right.
It's really scary to navigate new territory, which nearly conflicts that. So you have to
Right.
really take people on and so that's why I like teaching in person better, because you get to feel the vibe or feel the response of the room. Because when you feel that people are a bit uneasy with this, we can
Right.
discuss that out, and we can make it non-threatening. And I always like to go, that's exactly what I used to do too. I used to
Right.
tell people to avoid doming, because that's
Yep.
exactly what I was taught, and that's
Yeah.
exactly what I believed at the time.
Yep.
And you know what? It was scary for me navigating and kind of starting to push those boundaries. But the more we research, the more we do clinically,
Right.
even to test those boundaries, the less concerned we get.
Right.
And I try to contextualize it in different ways to help people understand, like, different people have different ways of learning and ways of rationalizing, and even things like particularly with diastasis and dome, and there's always a
Why does it have to be
huge
something?
there's always something that's so strong, and strong opinions. And I'm
Right.
like, it is a really strong, or is a really clever adaptation. And actually the stretch is there, like, and if you don't, nothing bad's going to happen. It's actually the pressure's going out that way rather than going somewhere else. I'm like, it's probably great.
Right, that's good. You don't want the wicked stress, maybe.
We don't like the aesthetics of diastasis in particular. So and then that brings
Right.
in that whole multi-dimensional component that diastasis really is. And
Yeah.
it's interesting because we've talked so much even about research and some of the frustrations, but one of the things I was working on before I jumped in this call and I was trying to scramble to get an extension for my ethics put in for a study that, when I was looking back, that we started probably plan in 2021, got ethics
Oh, wow.
for 22 or so, and like it's been ongoing, and that's for a diastasis rectus abdominis questionnaire. It's been led by Monserrano Ocampo and she and her team, and basically it's a biopsychosocial tool because at the minute diastasis is so indirectly distance focused and so physical, like in the way, like it's very mechanical, like, and it's not really considering that whole person attached to it. And the nuances, because you can have someone who has a 5-finger width separation who is back at the gym, it isn't limiting them, they don't really notice they've got it. And you can have someone with a 2-finger width gap who's totally, their life has stopped because of it. So we need to be dealing with that individual, finding out what concerns them about this, what's limiting them about this, and what can we do about it.
Yep. No, and I feel like we've gone kind of full circle here, is like, and I think that's a really hard thing to quantify in the research, is you do have all these parts and pieces, and it really does depend on that person in front of you, where their concerns are, body image, their past history with, do they have body image issues or eating disorders or things like that? What kind of stuff does this experience mean to them? And that, again, you can have all the objective findings in the world, but if they don't feel good or safe or have a good quality of life that they want, then it really is a problem. And again, how do you quantify that?
Well, I went down a little bit of not a research rabbit hole, but like I've probably had, as anyone who's doing a PhD will know, that the plans evolve as they go. Like what you initially set out to do might change along the way. And
Yeah.
because I'm really wanted to make this like clinical practice and explore the lived experience more, I'm actually building into the next part of my study. I'm actually doing a feminist phenomenological approach. So I'm trying to go into that type of approach to understand the lived experience and the theories behind it, and particularly taking that feminist lens, because society and different things creates different beliefs, different understandings, different what we consider to be happening, and in the world we live in, maybe how we engage, interact, do everything. So I want to see, can we harness any of those things out and see what's going on. But yeah, like I find stuff like that really, really exciting. But then it's not your quantifiable mechanical measurement study, which I know then you have your pure quant researchers who think quant stuff's the way to go. But I'm like, it's the lived experience for me that is so important.
Well, and to go back a little bit too, like I've been spending more time educating patients about the history of whatever they're coming in for and what we understood, and I think sitting here 25, 26 years out, they see that as like legitimate perspective. I'm like, look, when I first came out, diastasis, like, did you do the weird thing where you would take a TheraBand and pull, wrap it across and pull both sides together?
Is that Elizabeth Noble technique?
Oh God, I don't even know. But the thought process was, if you train the sides close together, then they'll learn to stay that way, which could not be further from the truth, And then I explained to people too, like my oldest is 14 now, and I had this idea that I wanted to run through my pregnancy, but there was no, like, there was no plan, and there was no place to refer to. And there was same thing with postpartum. Like there was no plan, there was no clearance, there was no anything. And when you have somebody that says, well, why did no one tell me? And I'm like, first of all, we're on this like conveyor belt that just keeps repeating itself, which drives me nuts. Everybody keeps going over the cliff, and we need to stop that. But you have to understand too, parallels in research, and I think Christine Yu's book did a great job of this. And then Danielle Friedman, who wrote I think it was like Let's Get Physical, or I can't remember what it was, but basically it was the Christine Yu version of exercise, is just getting women to be able to exercise, getting women to be accepted as, bench scientists, to ask the questions, to, involve women in research subjects, period, was such a novel thing. And this is where I'm just like heartbroken right now. And y'all are going to have to take the extra weight right now, is that I feel like we've come so far, in so many women I know are now in research, or they're straddling that clinician research, role. And we're asking good questions. And here in the States, we're just shutting that down right now. And it's infuriating, because I feel like we're finally getting some legitimacy, not only as athletes, not only as researchers, as clinicians, kind of asking these amazing questions. And y'all are going to have to pick up the extra weight, because we can't really help you right now.
I honestly, Carrie, I look at that from afar in disbelief. I'm like, this is a joke. Like, it's near like, is this April Fool's? Or like, it just seems so unreal to be, anyway. But it's when
Yeah,
I look back, like before I was ever even involved in research. Actually, if we go way back to 2019 when we put out that white paper, because we weren't researchers at that point of view, we were
right,
frustrated clinicians who
right.
were like, there are no guidelines or no support, and this
No.
makes no sense. Like they have returned to play after ACL, they've returned to play after shoulder,
Right,
anything. Like they've returned to
right.
play after everything. What about women? And we stood on a stage, Emma and I, in Santry in Dublin at a big sports medicine conference that I didn't realize was as huge as it was. But there was international speakers. It was really exciting. And we stood there going, this is a call to you in the crowd, to the researchers in the crowd. Please don't ignore women
Yeah.
in research. Like, we are extrapolating here from a lot of stuff based on men,
Yep.
or, there's nothing that we need to be studying women. So I'm putting that out to use. And like, we spent that whole talk highlighting the lack of research that there was. And
Hmm.
since that, it hasn't even been 10 years yet. And I feel
I
like
know.
there's been
I
an
know.
abundance. Like, it's really exciting. Like, I find it like every
Yeah.
day I'm getting a notification about something that's coming up. And I find it's nearly hard to keep up.
It's
Um,
very hard to keep up. Yes.
yeah. And like, I'm like, but it's so exciting, and
Hmm.
things have changed, and even how I practice has changed. Like, everything's
Yes.
always evolving. So I agree with you that it's really frustrating, but I would like to think that as a collective, everything will keep chugging along, and we'll be taking news with us,
I
and
think
and,
it
and it
will.
will all come good again.
Thank you. No, and we appreciate that. But again, back to the history, like, I think it's so validating sometimes for people to hear, because we forget, because we've been in this so long, that there's so much in medicine and so much in this that we don't know. And I think the average person still, well, used to look at, the answers are there, and we just need to go to somebody, they will tell me what to do, and it will get fixed. And obviously, as clinicians, we know that that's not the case. But when I tell people, look, I treat completely differently than I did a year ago, 3 years ago, 5 years ago, like, I wouldn't even recognize myself 10 years ago, 20 years ago, then I think they understand a little bit more that, we're still trying things out. And again, that's why I always love the clinician part of it, is that, and I think that was the coolest thing when I first realized that you existed, was you were doing the mashup too, as was I. And I was like, oh my gosh, there's people doing a mashup and we don't even know each other, and we're doing it simultaneously in the same universe. And this is so cool.
I know, it's like when you meet people, obviously, it's like I love that aspect of people, because my big thing is that, as I keep saying, like, that translation from science into practice
Yeah.
is difficult. So even when we have
Yeah.
really good studies, so if we think
Mhm.
of the OGs out there who are doing amazing studies that actually tell us really big
Right.
things, but how do we, even those can be difficult to like, you can't generalize them to everyone and bring them into
Right.
practice. A lot of things
Right.
are nuanced. And so I find that one of the biggest things that I'm trying to instill in clinicians developing in this field is clinical reasoning, because sometimes I feel like the
Yes.
clinical reasoning is losing its
Yes.
weight, and people coming out of uni. I'm like, it's not about protocols or like to-do lists.
Mhm.
It's about listening, and listen to that patient. It's not about you running through what questions you want and getting a yes no answer.
Right.
It's about listening, because they
Right.
will tell you something that will actually make you think, you go, oh, hold on, I need to actually ask about it. They'll say something to you that makes
Yes.
you think. So
Yes.
it's that clinical reasoning aspect. And even with the fact that we're never going to have this, with the majority of people we treat, we're not going to have green light on every single question that we ask, or anything single
Mhm.
thing we check. We're going to have some that are a bit, flagging, some that are not an issue, and then we have to make
Right.
that risk benefit analysis, like what's the overall benefit to this
Yeah.
person. And more than not, it's to keep people physically active, because we know that that's the answer to everything. Every medical condition going, one component of its management is physical activity, because of the
Right.
huge benefits that it brings.
Yep.
It's interesting because one of the in a book chapter that I'm writing with an evolutionary scientist, we've looked at kind of the evolution and of the human form and what that's meant for females in the pelvic floor. But like there was a huge, even our evolution and changes in diet have had huge metabolic like
Mhm.
changes for us as human beings. And so we rely on those active lifestyles and things to kind of
Right.
be counteracting some of the predisposition we're going to have to certain metabolic conditions.
Yeah.
So it is all about, it's like everything you're seeing from the postpartum running or postpartum guidelines coming out and everything, the benefits of exercise, we
Yep.
know it. Everybody knows it, and we need to. And
Yeah.
I used to work in cancer rehab, and I found it when it really went through a big development area as the research evolved, where we went from, I suppose, wrapping people up and, limiting them because they were fragile, to go, no, well, actually, this person undergoing treatment still needs exercise because that's going to reap rewards and keep
Right.
bone density up, muscle mass up, and actually help them tolerate their treatment better. And so
Yeah.
it went through a big paradigm shift. And I do think that we need to really push for the woman across the lifespan and break down a
Yeah.
lot of those barriers that are existing.
Yeah, no, it's very much kind of looking back at it, and I've been doing this a little bit more recently, and diastasis is a great example of like, are we inducing deconditioning out of fear and being able to go back and analyze, okay, yeah, we might have been doing that. There's really nothing that we're seeing right now that says that we need to. How can we encourage people to start being active sooner and that they don't need to necessarily modify as much as we might have previously thought during some of these transitions, in life? It's the same, I'm sure you're running into this too. It's the same kind of dumpster fire going into perimenopause and menopause right now. I'm like, oh my God, you got to do this. It's
Myths.
like,
Yeah.
oh, all the myths and stuff like that. And I think what I'm seeing a little bit sooner is more researchers biting back and saying, actually, no, um, we don't need to make this minutia oriented. We don't need to get in the weeds on a lot of this stuff. Some of the same principles hold true. And I appreciate that people are saying something a little bit sooner, because I feel like, at least, and maybe I've had my head buried in the postpartum pregnancy world for too long, but like I feel like the nuances have really had a chance to kind of fester and gather root, and it's going to take a little bit to shift that paradigm. And again, how many I come back to this in the States all the time, is like, how many people in general are unactive and inactive, and how do we just encourage activity on a regular basis, much less in pregnancy, much less in postpartum, much less in perimenopause and menopause and those sorts of things. So like, we have these obscene like points of privilege where we can see these nuances that are really important, and we're making these progressions. But when we come out to that 100,000-foot view, we really need to just, activity's good, let's keep doing it as much as possible. It's like we go in and then have to zoom back out again.
Do you know what? It needs to go way upstream, because that's what I
Yeah.
see even with the 4 kids I have. Like if you let them, they would spend their day on a device. Like they would
Oh
happily
yeah.
have their head
Yeah.
stuck in it. And so devices have to be removed. And then suddenly they're like, oh, what? They're initially they're like, we're bored, right?
I
There's
know.
nothing to do.
Good.
I know, like there's there's lots to do. But then eventually you see them go outside and play, and then suddenly they're having fun outside. They forget about
Right.
devices. They're good. They're being physically active, and that's what lifestyles should be like. But we're seeing more sedentary behaviors and
I
starting younger. And if
know.
you embed that young, are you
Yep.
really going to be active as you get older? So it's trying to really get people that buy in for physical activity, build that developmental baseline of function, and get them enjoying sport and activity. But as you said,
Yeah.
even the education, like the young ones should be getting the education about the benefits of physical activity really young, so that keeps building up and up and up, and they know why they want to keep being active.
Yeah.
But it's definitely, you can see it. Like if I compare my childhood to oh, should we play
Yes.
it? Maybe I look back. I don't know. Am I one of those people who now looks back with rose tinted glasses, in the sense that I totally exaggerate what we did? But like I'm like, we played outside all
We did
day,
all the
every
time.
day,
We did.
like all the
Yep.
time, like hail,
Mhm.
rain or snow. We were outside running about
Yeah.
with friends. It
Yep.
was all active. It was
Yep.
playing games, and I'm like, and I'm like, so yeah. But I've had, it was interesting because for the last, we've had parties the last weekend in my household. So we've had big bouncy castle, like an assault course type one that we had up and rented out, and like just seeing them like all day, every day, like sweat dripping off my kids. You know what I mean? Like proper activity. And I'm like, that's the way they should be playing.
Yes. But it's interesting where, we're fighting for more activity and, getting research and things like that. But you look in the rear view and we're like, oh my gosh, do we need to, go
Mhm.
back and double down and make sure that our kids are staying active so that they are gonna know that this is normal as adults. That's a really maybe you should study that. No, I'm kidding. You're like,
I have to
I'm
say,
done.
one of the other things, I was actually talking to a colleague today. I was talking to Jenny Bond the other day. It was like, Rania, I hope you're still working on saying no to things. I'm like, yes, I am. I am working on saying no.
It's so hard because it sounds like you're like an idea person too. Like, I finish the podcast episode asking a couple questions, and the first one is like, book you're reading or podcast you're listening to right now, and I'm like, I don't know if you have an answer. Like, you probably don't have time.
I don't. I'm reading. I actually have a book here that I'm reading, and it's part of my. It's called Second Sex. It's one of
Okay,
my phenomenological. So I'm going back into the literature of like
okay,
early researchers in that domain to see what they
mm-hmm.
were doing. So I
Oh,
am
interesting.
interested in it, but I feel like the fact that I need it from a PhD is making me read it. Whereas if it was just pure for fun, which I'm enjoying, I'd
Right,
deprioritize it. If you know what I mean, because I keep thinking I
I
have other
do.
things hanging over me. But I've got
Yeah.
better at listening, so I do find that when I'm say this weekend I'll be traveling to the airport. So I have a 2 hour commute to an airport either side. So I listen to podcasts then. That's when I listen to
Oh,
things.
good. Okay, great.
Sometimes it's stuff like your
Yep.
podcast. Other times it's like real no-brainer stuff like my therapist ghosted me or something that's just real, nothing to
Mm-hmm.
do with it's just light laughs.
Yeah. You know what though? I found the mashup with there's a couple running podcasts that I listen to that there can be a smattering sometimes of like some good information, but also like a lot of storytelling. I'm a huge fan of Des and Kara have Nobody Asked Us. So it's Kara Goucher and Des Linden. Love it. It's
Oh,
hysterical. You should check that one out. There's Allie on the Run. She does, it's like the number one podcast, running podcast in the US.
wow.
And she does a lot of interviews and stories of runners. So you get a lot of their backstory. But the one I really do like, and they've mentioned you before, I've
Oh,
told you about
wow.
this, is the Trail Society
Oh,
podcast.
I need to look that up.
It's so good.
Okay.
It's a bunch of trail runners but a bunch of it's strange because some of them are like going to med school and PhD, so they're really smart people, but they're ultra runners and they talk about food a lot. They talk about iron a lot. They talk about fueling, and they have a section of the podcast where they dive into kind of research and things like that, which is really awesome.
Okay.
So yeah. All
And is
right,
it
my
research?
friend.
How did they know me?
Your papers, things like that. Yeah. No, and I've sent them before. I'm like, you want to talk to Grania? Trust me. You want to do that?
Thanks, Corey.
You want to do that? So, all right. I know we didn't really dive into all your papers, but like whenever I can get a chance to talk to you and be like, how do you think? Because sometimes I just think I'm crazy or weird or something like that. And I want to know how other people who I
You've a good
totally respect
cognitive
be like,
brain. I like that.
yeah, exactly. But like I totally feel the critical thinking piece. I totally feel that like um, just understanding subjective I think is so incredibly important. So for those of you that like are in clinical care and you're reading this and you're like, okay, well now what does this mean? Still go back to those big pieces and look for those gaps because and it's again, it's all coming back to that nuanced, individualized kind of stuff for sure. So but no, thank you so much for always sharing the stuff that you're doing and, putting out so much good information. I know you're doing a lot with rugby and ultrasound. We can have a whole other podcast on ultrasound. I would love
I
to
know, I
geek out
love
on
practice.
that.
That's what I was going to say. Actually,
Yeah,
I love, yeah, we should do that sometime. But
yeah,
thank you for everything
totally.
you're doing and keeping the conversations going, Karen,
Yeah,
because that's how we need to be able to, it's getting messages to people in all
yeah,
these formats,
totally.
but also not just where they're hearing it, where they're getting the discussion of it, which is so
Yep,
important.
exactly, exactly. All right, my friend, always a pleasure. If you guys want to follow her along with her, Grania's absolute.physio on Instagram. Thanks again. I can't wait to
Thank you.
do a Active Mom After Dark.
Have we ever met in person? No.
No.
Oh, sorry, 'cause I feel like we have, but yeah, so we need to do an After Mom After Dark, after
Yeah.
Mom podcast after dark.
We'll plan that offline.
Okay.
All right. Thanks so much. If you're navigating pregnancy, postpartum, or perimenopause, whether personally or professionally, check out all our free resources and upcoming courses at carriepagliano.com. This podcast reflects the opinions of Dr. Carrie Pagliano and her guests, and it is for entertainment purposes only and should not be considered medical advice. Always consult your healthcare provider with any medical questions. If you enjoyed the episode, please take a moment to leave us a 5-star review on your favorite podcast platform. And thanks for listening.